Well, buenos noches. Can you see my screen here? Not yet. Here. Can you see it now?
Yeah.
Okay. Well, buenos noches. Thank you so much for having me. And I'm very glad to be with you. I wish I were there in person. I have been to Peru and it's a beautiful country. So I'm going to share with you a passion I have, and that's to talk about the visual manifestations of migraine. And so I'm going to talk about typical migraine aura and try to explain why blur is not an aura, then list complex migraine symptoms as well as aura that come without headache, and talk about why we need to be able to recognize aura because it is a vascular risk factor. And then I'm going to talk about some things that accompany migraine: visual snow and how do you differentiate it from aura, photophobia, how you can treat it and diagnose it. So I'm going to start with a case. I'm going to show you this video if it works, of Mike. He's a 30-year-old teacher. He has a family history of migraine in his mother, and he has attacks that start out as a blur, and he can hardly describe it. And then the spot slowly grows to the right side, and when the spot goes away, he has a headache with light and sound sensitivity, nausea, and then the aura can last up to 40 minutes, but the headache lasts all day. So now I'm going to share my screen with the video and show you what an aura looks like to the person who has it. So this is...
Like, before we go, can you get that screen over at Hardware Hanks? And also, you know what? We've got to trim the hedge or it's going to look really horrible by the time we get back. I'm trying to think what else. Oh yeah. Can you bring all the storm windows down on the bottom floor so that we can, you don't look too swift. Mike, are you listening to me? You look dazed. You're not getting a migraine, are you? Look. Oh, Mike, we are leaving for Massachusetts tomorrow. You can't get a migraine. I need help to get packed and to get ready and to get these hooligans out of here. Do I have a...
Okay. I'm going to stop sharing that one. I'm going to start to share my... Okay. Now you should be seeing my...
The long war on cancer has left us well short of victory. Radiation flashed on in the...
Let's see here. How do I get that thing to stop? Okay. Well, I hope that helps you. Can you see my screen?
Yeah.
I hope that helps you see what a patient experiences with aura. First, it starts as a blur, but you could see those zigzaggy lines coming on and getting bigger and bigger and bigger and bigger. So an aura, you can have a prodrome to migraine, and some people say I've got blurry vision or something that starts things off, but that's not the aura. Mike's aura was visual, and 90% of auras are visual. Some are sensory, some can be speech and language, even motor. There's a thing called brainstem aura and retinal migraine, which are very, very uncommon. But these migraines with aura usually develop over 5 minutes. You could see how that kind of progressed. Sometimes people get more than 2 symptoms in succession, like they get the visual thing, and especially if it goes off to the right, that they can have their speech affected, and the aura can last up to 60 minutes, but usually not. And usually one symptom is unilateral. there's usually a positive symptom. You saw those scintillations, that zigzaggy line, and often it is followed by a headache. So migraine with aura is present in about 20% of individuals. We don't use the old terms classic migraine, ocular migraine, because we say migraine with aura if there's an aura. And it can be triggered by light, flickering, complex patterns like Venetian blinds or very black and white patterns. And it's not just blurring. About half the people with migraine will say my vision is blurred during the headache, but you have to really go after the symptom. Okay, do you see zigzag line or a spot that gets bigger and bigger and bigger? And this is a typical aura, just like Mike's, where you see the scintillations in different colors going off to the right side. This was actually drawn by one of my residents. And you can see that in people who've cataloged auras, most of these are zigzag lines or scotomas, like we saw with Mike. But I want to remind us all that not all visual phenomenon are migraine auras. Now, all of us see patients that have floaters, posterior vitreal detachments, even retinal detachments that start with maybe a flashing light and then floaters. Some people can see what we call self-light of the eye, meaning they close their eyes and they can see clouds of different colors coming. Many people see it, some people don't. And this is just a normal phenomenon that's been known for a long time. People who have migraine can have little flickering in their vision, and it can come from the retina. It can come from migraine too, but most of the time something else is causing that flickering. Photopsias, we see people that have normal entoptic phenomenon, like they've got traction on their retina. And then sometimes people describe shimmering peripheral lights in their peripheral vision. Then we have to be thinking about, do they have papilledema? Could they have retinitis pigmentosa? Are they on some medication that will give them that shimmering? Or could they have cancer-associated retinopathy? And then, of course, we see patients with glaucoma or medications that describe halos, and these are not aura, or metamorphopsia, and that is not an aura. Ophthalmologists are really good at being able to distinguish a lot of these phenomena. But people with migraine are very visually sensitive. And one take-home point for you is you have a patient with migraine in your chair, you are going to have a visually sensitive individual. That means that some of them can see their red cells and their white cells in their retina running around, and they can be overwhelmed by their floaters, and they're a little bit more prone to flickering, and all of this is not aura. I don't know if you have a blue field entoptoscope in your office, but I love the blue field entoptoscope because I have my patient look in and they go, oh, that's exactly what I'm seeing. Well, what are they seeing? They're seeing their red cells and their white cells floating around and running around in their blood vessels. So it's really a handy thing to help people distinguish what their symptom they're trying to describe to us. Now, many ophthalmologists worry about, well, am I missing something secondary? And we have this mnemonic for headaches, and I'd say it applies to aura as well, that we snoop for secondary problems, like do they have a systemic symptom like a fever, weight loss, or a systemic illness like cancer, or they're immunocompromised? Any other neurologic symptoms or sign? Is the onset of the headache or the visual phenomenon, boom, less than a minute? Remember, I told you that auras are often 5 minutes or more. Older people, and we'll talk about older people getting auras, but if it's a new onset of an aura, I'm always a little bit more careful about that. And then I look for previous headache history, progressive headaches, postural headaches that come with visual phenomenon, like people who've got high pressure or low pressure, or a headache or visual phenomenon that's caused by Valsalva maneuver, or if somebody has pulsatile tinnitus, or visual obscurations like pseudotumor cerebri syndrome symptoms. or if they're pregnant. So the next patient I want to share with you is an 84-year-old physician. He has a family history of migraine. He's had migraine with aura since his 20s. In his 40s, he began having aura without headache. And his scintillations usually start and go off to the right. And when they do go off to the right, he often will have speech problems. Well, one day he was in a meeting and he had his aura, then he couldn't understand the slides, and then he couldn't talk. And of course, that led to a workup in the hospital to rule out a stroke or a TIA. He was placed on a calcium channel blocker because he's on an anticoagulation for atrial fibrillation. But this is migraine aura without headache. It's a typical aura, but no headache follows. It used to be called migraine accompaniments or acephalgic migraine, and some people have called these late onset migraine accompaniments or LOMA, and it's almost always visual, and it usually doesn't decrease with age, but starts after age 40. The big problem here is how do you differentiate this from a transient ischemic attack? Well, a transient ischemic attack is going to be visual loss. And remember, I said migraine is going to have positive phenomena, you know, those sparkles, zigzag lines, and flashing lights. A TIA is going to be unilateral and static and abrupt in onset. Boom, it happens. They get transient monocular blindness. Whereas migraine has that slow progression over a period of time. The sensory symptoms of a TIA are negative. That means it's numbness. Whereas in migraine, they're positive, meaning they've got paresthesias or tingling in their fingers, and also can be a gradual and onset. And often in migraine, it's around the hand, so we call it chiro, and oral around the mouth. And TIAs are usually not stereotypic. But when you diagnose aura without headache, you have to really think about it because you got to make sure it's not a TIA. Consider seizures. These usually last seconds up to maybe 1 to 3 minutes. And sometimes they're pinwheels, they're balls, they're rapid and brief. And they always occur in the same visual field. They don't switch right to left, and often they're repetitive. Tumors can be heralded by a typical aura. So a new aura in an older person who never has had migraine, you've got to work it up, often with an MRI scan. Other things to consider are reversible cerebral vasoconstriction syndrome. This is usually an abrupt onset of a headache, and then maybe some visual symptoms. Amyloid angiopathy can be seen in older people and can be started, they can have auras as a symptom of it. Arteriovenous malformations, dissection, vasculitis, autoimmune disease like lupus or antiphospholipid antibody syndrome. And if the person is pregnant, always think about eclampsia or severe preeclampsia. Now, I told you that auras are important for another reason, and that is in many studies that have been done. Now, we've got many, many studies that have shown us that people who've got migraine with aura have a higher odds ratio of a vascular disease, stroke, heart attack, or even death, even higher than those without aura. And if it's associated with obesity and an unfavorable lipid profile, it can be worse. And those who smoke and have aura or aura with diabetes, they're at even higher risk. Women in menopause who have a lot of hot flashes and migraine with aura have also an increased risk of cardiovascular disease. And of course, we all know that we don't use high estrogen contraceptives in women with aura because of the increased risk of stroke. I'm going to switch gear and talk about a very rare disorder called retinal migraine. This is a monocular visual disturbance, usually scintillations in one eye only. Now, all of us know if people have a migraine aura. If you've ever had an aura, you would swear it was in your left eye or your right eye. But if you cover each eye, you discover, oh my goodness, as I'm looking at this page, it's in both my eyes. But anyway, these are documented in one eye only. And usually by clinical field exam or else the patient drawing their monocular field after instruction. And you have to have two other findings. One is it has to spread gradually over 5 minutes. So this is not transient monocular blindness, where you get it, boom, and then it lasts for a while and then it goes away. So, and the symptoms can last up to an hour and are almost always accompanied by a headache within 60 minutes. We all know monocular visual loss has a broad differential diagnosis. It's very rare, and you have to rule out retinal vasospasm. Another unusual migraine symptom is called Alice in Wonderland syndrome. And this is a perceptual disorder where people feel like their body is too big for this space or too small for a space, or things look way far away. That's called teleopsia, or paleopsia, meaning things are too close. It's named after Lewis Carroll, who had migraine, the book Alice in Wonderland. And it was first described by Carl Lippmann in association with migraine. But migraine is not the only cause. Seizure, infection, and autoimmune encephalopathy can also cause Alice in Wonderland syndrome. This is not common. These people need to be seen by a neurologist and probably get a scan. All right, now I'm going to switch gears. I've got a 17-year-old young man sent to me for persistent aura. He has a family history of migraine. He has had typical migraine without aura and occasionally has a migraine with aura. He's a good student, but he says, I have silvery lines that are present whenever I'm concentrated. And if I look at the sky, or in Utah, we have snow because we have ski resorts, I see these floaters all over the place. And I've got this grainy vision as long as I can remember. So I showed him these pictures, and these are the pictures I showed him. This is grainy vision where you can see through it. His vision was 20/20. He had these prominent floaters. He could see other things in the sky. He did not have palinopsia, either the kind where you see something trailing behind you or looking at an object and then looking away and seeing the same object. So he said, I've got these three things, and this is clearly visual snow and not persistent aura. And as a ophthalmologist, one thing you have to know is that visual snow also can come from the retina. Remember that all that flickers is not visual snow. In fact, this is a patient that we had in our clinic. She was sent to us. She was middle-aged. She was like 55, and she was sent to us with visual snow diagnosed by a neuro-ophthalmologist. However, she was an atypical demographic. She was older, kind of late onset. And when we dilated her, we saw these creamy lesions in her retina. And we could see that her fluorescein was not normal and her ICG was also abnormal. And her OCT was, of course, abnormal as well. And she had an abnormal visual field. And what she had was multifocal choroiditis. And there are definite retinal conditions that can be seen that look and sound like visual snow, but they're not. So choroidopathies, cancer-associated retinopathy, melanoma-associated retinopathy. There are a host of other things like traumatic brain injury, and stroke has been associated with snow, etc. So it's just important to know that our job in ophthalmology is to rule out any retinal cause of visual snow. And if it sounds atypical or it's atypical demographic, because most of these visual snow people are young. So the criteria for diagnosing visual snow are the dynamic, continuous snow, and they got this name from the old analog black and white TV sets that many of us who are older can remember. And it looks like snow on the television set, but it just makes everything look grainy. And then at least 2 additional symptoms, palinopsia, either form, the trailing imaging or looking away and seeing the same object, enhanced entoptic phenomenon like excessive floaters, or that self-light of the eye I told you about, or photopsias, photophobia, or nyctalopia, impaired night vision. And these are not typical of aura because they don't have the buildup. They're continuous, they're going on all the time, and it's not explained by a separate disorder. It's seen in women and men, and most people with visual snow do have underlying migraine or headache. About 20% have anxiety or depression. At least a quarter or more have had visual snow since the beginning of their childhood. And there's a high incidence and prevalence of tinnitus or ringing in the ears. And there are PET studies that show that the brain function is altered. So we think that this is a problem where you can't dampen your vision to get rid of the snow. So beware of snow developing later in life and think about secondary snow. And usually just telling people what's going on is all you need to do. Rarely medications or lens filters can be helpful. Next, we're going to talk about this woman. She is migraine, but developed photophobia ever since a mild traumatic brain injury, and she's not leaving her house. She was wearing dark sunglasses all the time, and you, the ophthalmologist, have looked at her, and her exam is normal, and her neuro exam by the neurologist is also normal. So photophobia, it's a really difficult symptom. 80 to 90% of patients who have photophobia, and this study was done, you take 100 people, 80 to 90 of them, if they have continuous photophobia, are going to have migraine. And it's part of the major diagnostic criteria of migraine, including photophobia, disability, and nausea. And it's the most bothersome symptom of migraine. And if a person has photophobia all the time, think about migraine. But we, as ophthalmologists, know that there are many causes of photophobia. In fact, we are taught to look for iritis and ocular inflammation and dry eyes, and look at retinal causes like retinitis pigmentosa, albinism. But I want to warn you that photophobia can be a symptom of many brain problems too. Meningitis, pituitary tumors can present as just photophobia. The most common are migraine, blepharospasm, traumatic brain injury, and interestingly, progressive supranuclear palsy. And then there's a host of other causes as well. So how do you make the right diagnosis? First, I look for a central cause. Did they have a head injury? Could they have a pituitary tumor, meningitis? Are they on some kind of medication that might cause photophobia? Then I really carefully look at the eye, because at the slit lamp, I want to make sure they don't have iritis, episcleritis, scleritis, inflammatory disease. And if that's the cause, of course, you know how to treat that. Then I really look for dry eye. We add a drop of proparacaine into the eye to numb up the eye and see if the pain and photophobia go away. Then I do a Schirmer's test for dry eye, and it's very common to see dry eye contributing to photophobia, even with the migraine, and we'll talk about that. Then look for a retinal cause, and that'll be hemerotopia, where everything seems way too bright, or nyctalopia, meaning they're having trouble seeing at night. And then blepharospasm is real interesting because we can all make the diagnosis when people are blinking, blinking, blinking. But some people have reflexive blepharospasm, meaning that when you shine the light in their eye, they go, oh, and they close their eyes for a long time and can't open them. And that can be a form of blepharospasm, and it can respond to onabotulinum toxin like we treat typical blepharospasm. And then look for migraine, and really have to ask about migraine and ask about headache, light sensitivity, and nausea. And if you don't have a diagnosis after you do all that, then go back and start over. We looked at the etiology of photophobia in our clinic, and the most common causes were migraine, dry eyes, ocular conditions, eye trauma, head trauma. And those were the most common causes in our clinic. why would dry eye symptoms contribute to migraine? And this is a woman who's 32. She has a history of migraines that have become chronic, and she's coming to you because she's got grittiness, she's uncomfortable. Her eye exam is normal except for her Schirmer's of 6. It's not absent, but are these related? So from this, we have to think about how do we get tear film, and it's really nice to look at this beautiful diagram by Dr. Flugfelder, where remember that the cornea senses in the trigeminal system, the first division of 5, going back to the trigeminal nucleus and connecting with the trinucleus, the trigeminal cervical complex, or the nucleus caudalis. It also connects with all the autonomic nervous system, both the parasympathetic system, which also, of course, innervates our lacrimal gland and provides us with tears. So it's really an integrated system. And when the eye is dry, the trigeminal system senses it, tries to make tears, and there's kind of a loop that affects the trigeminal system as well as the tear film. Now, we looked at this problem because we noticed that all of our patients with chronic migraine were complaining that their eyes were gritty. So we did a dry eye questionnaire, and we found that all of them were positive in the questionnaire in these 19 chronic migraine patients and 30 controls, mostly women. But interestingly, our basal tear secretion, corneal sensitivity, tear film breakup time were actually pretty normal in our chronic migraine patients. But what we were surprised to find is we were doing corneal microscopy on these individuals, and their nerve fiber density was reduced, and their nerve fiber length was also altered. And this now has been confirmed by Shetty in the journal Cornea, and more recently in episodic migraine, and just now in the last couple months, a report about dendritic cell changes in episodic migraine. And the question is, are these related to migraine, or does migraine create these over time? Is there some kind of neuropathic component? Does the dry eye contribute to the migraine, which I think it does? And so this led us to say, well, could the visual quality of life of migraine be reduced like it is, for example, with people who have dry eyes? And for this, we looked at chronic migraine, episodic migraine, and controls, and we did a bunch of validated questionnaires to look to see what we could find. And what we found was it was almost a dose response curve. So this is the National Eye Institute Visual Quality of Life. And in chronic migraine, it was way reduced. Episodic migraine was reduced compared to controls. But what we were surprised with is if you look at the visual quality of life, in optic neuritis, it was worse than optic neuritis. It was about the same as idiopathic intracranial hypertension, and maybe a little bit better than Graves' ophthalmopathy. So this tells us that migraine is affecting our visual quality of life in our patients. And we found that as the HIT-6, now the HIT-6 is a migraine score, how bad your headache is. And as it gets worse and worse and worse, you can see that the visual quality of life got worse and worse. So here's the chronic migraine is the worst, episodic migraine is next, and then of course the controls were the best. Now we ask the question, what could be driving this decreased visual quality of life? And because we wanted to know, is it just the pain? Is it ocular surface problems like dry eyes, or just what's going on here? So we found that it was affected a bit by how bad the headache was, and of course the OSDI, the Ocular Surface Disease Index, was way higher than normal controls, and their photophobia scores were higher. And what was interesting to us was that dry eye symptoms had really the highest correlation. So I think what the cornea is trying to tell us is that there's some shared pathophysiology in our patients who get these really bad dry eye symptoms. And it's probably stimulating this trigeminal nucleus caudalis in the brainstem. And it leads to this continuous trigeminal stimulation and central sensitization, so that even if they don't have migraine, they can still have eye pain from the dry eyes, even when the dry eye is actually treated. So it's kind of a form of what we call allodynia, meaning a normal, it should be a normal sensation, but it's not. And so many people have these symptoms of dry eye, and I think it's partially modulated by the autonomic system, and it could be mediated by what's called calcitonin gene-related peptide, which is a peptide in the tears, but also is a peptide that has been found to create migraine. So I'm going to talk now a little bit about photophobia and why we get this. Now, we all have a threshold. Imagine yourself going to a matinee in the middle of the day, and you come out into the bright light after the matinee and you go, oh, it's bright out here. And then it gets better right away. And Cowax did an algometry study where he showed that light shined on an individual decreased their pain threshold, meaning they could feel pain more readily if the light was shined on them. And then Vanagate from Norway showed us that in winter, where they have very little light, the light threshold is again very, very low. And as the summer comes, you have a higher threshold. And of course, a lot of people look at the sunglasses sign as associated with functional visual loss. And I'm going to try to explain that. So the first question you might have is, do you need vision to be light sensitive? And that answer came from an article where, and I was a part of this, where 20 migraine patients with light perception or no light perception had migraine, and during their migraine, they were indeed very light sensitive. All the people who had light perception at least were light sensitive. And so the answer is, of course, no. And for that, we have to turn to the melanopsin story, the intrinsically photosensitive retinal ganglion cell story. So remember that vision is, of course, picked up by the retina, taken by the optic nerve to the chiasm and then to the occipital lobe. That's our visual system. But this melanopsin system is very different. These cells, these melanopsin cells, project to different things. They project to the suprachiasmatic nucleus that entrains our circadian rhythm, helps us with sleep modulation, suppresses melatonin. They also go to the olivary pretectal nucleus to participate in the pupillary light reflex. They also do interact with the vision forming system in the lateral geniculate body. And of course, we think that they are intimately involved in photophobia in the posterior thalamus. And they're a very weird cell, this intrinsically photosensitive retinal ganglion cell. They're very old phylogenetically, like frogs, amphibians, almost all creatures have these cells. And what's interesting about them is they don't have many of them, and they get wide input, but it takes a lot to get these guys to turn on. Like, here comes a light for 1 second, and it goes on. And then once the light was on for 10 seconds, you can't turn these cells off. They just keep on firing. Their peak visual spectrum is the 479 nanometer, and they and sometimes you can treat with a FL41 tint, and I'll show you that, to block that wavelength of light. And what I think is interesting is that in animal studies, animals who had melanopsin, who had disruption of all their rods and cones, so they were blind, were still light sensitive, and animals without melanopsin were light insensitive. So kind of a really interesting pathway. But to get pain, we need the trigeminal system. And of course, we all know about the trigeminal system, the first division of 5. But I want to remind all ophthalmologists that the trigeminal system has one branch that goes to the dura. And that dura is innervated by V1. That's the same part of the trigeminal system that innervates the whole eye, and of course the cornea, which has the most dense sensory nerve fibers in the entire body. And that's why people who have their dura stimulated almost anywhere, where's the pain going to be felt? In the eye or around the eye. So this trigeminal system, can this trigeminal system meet the melanopsin system? And the answer is yes. Dr. Rami Burstein in Boston showed us that these two systems connect together, and then they go to the somatosensory system in the occipital cortex. And then we do have a role for sympathetics. So the sympathetics join the trigeminal pathway. And in this person, this is a lady that I met. She had a corneal, sort of a corneal injury that led to horrible light sensitivity. And then she could hardly move or walk or do anything because her eyes hurt all the time, and she closed her eyes and she had horrible blepharospasm. And so we did a sympathetic block on her, and her eyes just opened up, and we got rid of her light sensitivity. And then we did a study on other people who had the similar light sensitivity and found that that worked. And one of my colleagues did a study with blepharospasm to show that that also could help with the light sensitivity. Now the question is there an emotional component to photophobia? What about that sunglasses sign? And why is it so hard to take care of people with photophobia? If you're an ophthalmologist, I know you've seen patients with photophobia, and I know you kind of go, oh, what am I going to do with this person? Because there's nothing wrong in their eye. So in this study, we took patients who had migraine and interictal. That meant that they were photophobic all the time. And then patients with migraine with just photophobia with their migraine, and then controls who didn't have migraine. And of course, we found their photophobia score in the chronic migraine with interictal photophobia was really high. Non-photophobics were very similar to controls. But look at this. Depression scale was markedly elevated in those people with chronic photophobia, and so was the anxiety scale. So a lot of these people are very anxious individuals, and that is part of the disorder. So and this finding has been confirmed now by others. And was a wonderful study that where people were again, Rami Burstein and his colleagues showed that certain lights could cause negative emotions. So red light during a migraine, red light, yellow light, blue light could cause negative emotions. The green light, not so much. But here was what was interesting. He found that during migraine, a green light was pleasant, happy, relaxing. And this has led to a lot of people doing green light rooms, green light therapy. And I want to remind you that if you're examining somebody with bad photophobia, use the green light on your ophthalmoscope or your indirect, because you'll get a much better view. And this study has also been confirmed by others. Now, this study I thought was so important because this was animal models that help us understand this emotional component. So when mice are born, they're blind up till postnatal day 9. Only the intrinsically photosensitive retinal ganglion cells are active. So if you shine light on these mice that are less than 9 days old, they are squeaking and beeping and everything. They produce vocalization similar to the distress of being taken away from the litter or having a noxious stimulus. But if you take melanopsin knockout mice, they did not exhibit this behavior. And then if you cut off the brain of the little mice, you can find that there is activation of the posterior thalamus and activation of the amygdala. And the amygdala, remember from your neuroanatomy, is part of our emotional center. So that led us to kind of come up with this conceptual framework of photophobia as a symptom. Of course, the cornea and the trigeminal system are actively involved because this is where we get the pain, and we can get it from the dura, which can come from the migraine pathway or from the eye pathway to this nucleus caudalis. And then it's modulated in the posterior thalamus by the melanopsin system and modulated by both the parasympathetic system or the sympathetic system. And I think this helps us at least explain a little bit. Now, everybody goes, well, what can I treat these patients with? Well, the first job is make the right diagnosis and tell them what they have and why they have it. And then get these people who are living in the dark out of the dark. They've got to come into the light. Otherwise, they're going to be dark adapted all the time. Our job as ophthalmologists is treat those dry eyes and dry eye symptoms. We can use preservative-free tears, serum tears, anti-inflammatories, and then we can work with our colleagues and neurologists to treat their migraine, and we've got all kinds of new drugs out for migraine. Besides dark adaptation, green light therapy might be helpful for some. We found onabotulinum toxin done in a migraine protocol, and it can be done by ophthalmologists, can really help individuals with photoocular surface pain and photophobia, even without migraine. And anticonvulsives sometimes can be helpful. CGRP monoclonal antibodies, especially if they have migraine, sometimes melatonin because you're treating their sleep disorder, and then treat their underlying depression and anxiety. And rarely I've had to do that sympathetic block for people who've got kind of a blepharospasm-like picture. So I talked to you about colored lenses. FL41 tint has been known for, 25 years. And it is a tint that blocks that blue light, that 479 nanometer. And many people now are using designer lenses, blocking 490, 520, but not the green spectrum. So there's all kinds of work being done with different lenses. And Anat Galore in Florida has used TENS units, and here was a supraorbital stimulator, that a TENS unit that she put over this young man who had very, very severe photophobia and eye pain. That seemed to help. There is a commercially available device called Cephaly device, and it can be ordered on the internet without a prescription. So I hope I've convinced you that you want to ask your patient about migraine, because it's going to tell you something. These people are visually sensitive, and the visual system is involved almost all the time. They're going to be a little bit more light sensitive. Recognize aura, and aura is not just blurring, and then differentiate aura from a transient ischemic attack or a stroke or visual snow, and then make the right diagnosis about photophobia. And remember, these are neuroophthalmic symptoms and problems that can be solved by us. I did want to bring up this novel library. Dr. Z brought this up at the beginning, novel.utah.edu. This is a free virtual library to everybody in the world, and it has many collections from many of the luminaries like Dr. William Hoyt, David Kogan, Irene Lowenfeld. In fact, Irene Lowenfeld's pupil textbook is online for free. The Walsh and Hoyt textbook is online for free in this library. And for many people, we have many different collections, and our new collection is called Test Your Knowledge. And this came from Dr. Jonathan Trobe, where he shows a picture of some MRI scan and then says, what's the answer? And then you have to pick the answer. And I think what you may be interested in too is every single condition in neuro-ophthalmology has a handout in English. Here's migraine, for example, but look at this. It's got like 20 languages, and one of them is Spanish. So almost every single one of these diagnoses in neuro-ophthalmology in the patient portal has like blepharospasm, drusen, dry eye syndrome, eyelid myokymia, giant cell arteritis, hemifacial spasm. All are translated into Spanish, and they're free, downloadable for you in your clinic. And I just want you to be aware of this great resource put out by the North American Neuro-Ophthalmology Society that you can use in your practice. And with that, I'm going to stop sharing, and I want to take questions. I was told to leave some time for questions, so please go ahead and ask me anything. And I want to say gracias for having me.
Congratulations, Dr. Kathleen Digre. Wonderful presentation. Now, is there any question for the audience? Alfonso, ¿habrá preguntas?
And
in the
you
chat.
can say it in Spanish, and I'm sure Dr. Z will translate it for us.
Yeah. Any question for the audience? Alfonso, a chat, algo, nada?
No, no hay preguntas todavía.
Well, I have a question. For example, Dr. Kathleen Digre, what is the frequency of migraine aura do you wait until to treat with any drugs? What is the
Okay.
frequency that you wait?
Okay, so if you it's hard to treat the aura when you get it because it doesn't last that long.
Yeah.
You can prevent migraine with aura with a simple baby aspirin. That's my favorite drug. As long as there's no contraindication to aspirin. Aspirin's my #1 drug for anybody who has migraine with aura without headache.
Yeah.
And so that's what I would treat. The migraine medicines don't work. If you give a migraine medicine at the onset of the aura, it does not stop the aura. It will help with the headache, but it won't help with the aura. So if they have frequent auras, #1, you want to make sure you have the right diagnosis. But #2, you could suggest that a baby aspirin could stop the auras from occurring. So it's it's easy treatment.
Yeah, it's enough only one migraine aura in order to prevent the treatment or not?
No, if you've just got one, in let's say a month, it's not worth going on an aspirin every day. But let's say you've got an aura 1 or 2 times a week and it's interfering with your work.
Yeah.
Like you start to get the aura and you can't see and you're supposed to present to somebody and what are you going to do? You're going to want to prevent it. So it's a matter of how many auras that somebody has.
Okay. What is the favorite drug that you use for preventive treatment with migraine aura?
Well, baby aspirin is what I use as a preventive.
Preventive,
I use that to prevent if it's frequent. Now, a lot of people who have get the headache, get a lot of the headache piece, and they have migraine with aura, sometimes will add a calcium channel blocker like verapamil. That is very helpful sometimes for people with migraine with aura. But most ophthalmologists aren't going to be treating this stuff. They're going to give it to the neurologist. At least in our country, most of my ophthalmic colleagues do not want to treat auras or migraine or anything like that. They just go, okay, it's get it to the neuro-ophthalmologist or send it to the headache person.
Yeah. Do you consider palinopsia as a part of migraine for you? Palinopsia.
Okay.
Very frequent?
Palinopsia. That is such an interesting symptom, isn't it? So palinopsia has many, many, many different causes. It can be caused from a brain problem, but many times it's medications. Like some of individuals that are on clomiphene for trying to stimulate ovarian production and eggs production for people who've got infertility. Clomiphene has a lot of palinopsia. Some of the anticonvulsants also have palinopsia. Today in clinic, I saw a woman who was on topiramate, newly on topiramate, who had palinopsia, the trailing figure. So medications are my #1 cause of palinopsia. And then rarely it can be caused by stuff in the brain too. It can be a brain cause. And then, of course, it can come with visual snow. So if you have somebody with pixelated vision and palinopsia, that goes along with this whole visual snow stuff.
Would you consider, for example, visual snow syndrome, the true visual snow syndrome, as a part of migraine or different entity?
It's a different entity, but the people who have migraine and headache have a higher incidence of visual snow. So you can see people with visual snow without any headache or any migraine, but by and large, the majority of the people with visual snow are going to have underlying migraine, but it's not an aura. It's not a continuous aura like that kid I showed you. He just had that snowy vision, and that wasn't an aura, it was visual snow. And it's such an interesting syndrome because it's like noise in the visual system. just like ringing in the ears. Tinnitus is like noise in our hearing system. So it's a noisy, it's like noise. And usually we dampen the noise, the visual noise or the hearing noise, but sometimes in these people, they can't dampen it, and it's a brain problem. And most people, if you just tell them what it is and all this kind of stuff, they can just sit back, relax, and they're fine. But sometimes you have to treat them. And of course, they have a high incidence of anxiety. So you might need to have them see somebody for the anxiety, like a counselor or something like that, to say this isn't going to, make you go blind or anything like that. Do you guys see a lot of visual snow in Peru?
Yeah, yes, I saw some cases of visual snow syndrome. Yeah,
Yeah.
but what's your favorite drug for visual snow syndrome for you?
Okay, if it's not due to something in the eye, and that's our job as
Yeah,
ophthalmologists, is make
yeah,
sure it's not choroiditis, it's not something in the eye.
no,
Then, and most of the time I don't put them on anything, but the one drug that has been shown to be helpful is lamotrigine,
yeah.
lamotrigine. It's an anticonvulsant. And the other thing has been FL41 tinted lens, or this lens that blocks blue light, the melanopsin pathway again, blocks blue light, and it seems to be helpful for some people. For some people, it doesn't work, but for some people, it works great.
What doses do you use in lamotrigine
I start
in this
with
case?
very little doses, like 25 milligrams, and then slowly work up. It's a drug that you probably want to partner with a neurologist on because it's a little tricky to use.
Well, is there
Any
any
special
question, Alfonso?
considerations? Yes, Dr. Digre, any
Yeah.
special considerations to eye pain? How do you avoid eye pain in the
Okay,
clinic?
so you have to make the right diagnosis of eye pain. And we did a big study in our clinic where we looked at all the causes of eye pain. In the eye clinic, it was dry eye, conjunctivitis, and kind of those types of things were the most common. In the neurology clinic, it was migraine and then dry eye. But I have to say, we're really good at looking at eye pain. I use that same algorithm that I gave you for photophobia. I use the same algorithm for eye pain. I look for something central, then I look for something inflammatory in the eye, and then I look for dry eye, and then I kind of go down the list to look for what could be causing it. But I know eye pain and migraine can give you eye pain. So let's say somebody has eye pain, they're light sensitive all the time, and they're sound sensitive, and they're a little bit nauseated. You know what? And you don't find anything wrong in the eye. It's probably migraine pain in the eye. Sinus. People come in and they've had their sinuses all reamed out. It's all migraine. And it does. My brother came to me, said, "Oh, I've got bad sinus headaches." Well, he had migraine. And so he did all this sinus stuff and it never worked. But as soon as he started treating his migraine, his sinus pain, eye pain all went away. So that's why every ophthalmologist needs to understand that migraine is more than a headache, and it's also connected with all these visual things that we need to know about so we can help our patients get the right treatment and get seen by the right people.
In some
Thank you.
situation, an extreme rare, for example, rare migraine aura that lasts more than 1 hour, what do you think would happen
Okay,
in that case?
you can have prolonged aura.
Yeah,
And they are scary because prolonged aura can result in a stroke. So if you have somebody who has a aura that lasts more than 24 hours, you've got to get an MRI scan with diffusion to look for a stroke because that's very abnormal. That's not normal. It can occur. You can have it. And I've seen these very prolonged persistent aura without infarction, but it's very typical aura. It's not just, it's not visual snow. It's typical aura. And, it has this spot in their vision, and then you do an MR scan and it's completely normal, but you can map out this defect that's still there, homonymous defect. because remember, aura is coming from our occipital lobe, so it's going to be in both eyes. So yeah, those are scary. You kind of have to work them up for stroke if they're persistent.
Okay.
How do you distinguish?
Continue,
Yes. How
continue,
do you
Alfonso.
distinguish Alice in Wonderland versus a psychiatric illness?
Say that again. Sorry.
Alice in Wonderland versus a psychiatric syndrome.
So some of these people, the people like with photophobia and everything, they do have, remember I showed you, they have higher incidence of anxiety, higher incidence of depression. These things can be treated by their primary care doctor. And so that can be helpful to help them get better. So I have seen things that are psychiatric syndromes, but most of the time I find actually they've got underlying migraine or underlying other causes of photophobia.
How do you differentiate between visual seizure and migraine aura? Practical.
Okay, and sometimes that's tricky. But remember, a visual seizure will always be in the same place. And if people have pinwheels and kind of complex figures that they're not growing. They're just like there and they're doing their little rotatory thing or something like that. And they're always in the same spot, never a different spot. Those are the ones you have to get an MR scan or a CT scan and look for an underlying tumor, arteriovenous malformation, something else. EEG sometimes will pick those up. And when I've got people who've got really weird symptoms like that, I'll get an EEG and a scan of the brain to look for it. But they're much more complex. They're always in the same spot. They don't last like an aura, and they don't have that buildup. That buildup is so characteristic of an aura, and that really helps us feel more comfortable. Yep, this is an aura. It's not a TIA. This is not a seizure. It's not anything like that. It's an aura associated with migraine.
It's important to
There's a
time, for
question.
example, the duration of symptoms, the duration of the visual seizure, the duration important.
Yeah, the seizures are often shorter, like 1 minute, 3 minutes, something like that. And then that may not get a headache afterwards either.
And the frequency is important, yeah?
Yeah, and you can get lots of them. They get a whole bunch of them all the time. And remember, it's always in the same place. Like something going on in the same place. And then they get a visual field defect. If you do a visual field, they actually have a visual field defect going on.
Okay.
There is a question.
Yeah.
Yeah. Question in the audience?
Yes.
Yeah.
What do you recommend to kids and teenagers about headache in preventive medicine?
Okay. Luck would have it, at the University of Utah, we have a headache school. I don't have it all in Spanish yet, but I do have a headache school with handouts and little videos on all aspects of migraine. The American Migraine Foundation does have handouts in Spanish on migraine, and so there's a lot of information out there for people that is really good. And I know that there may probably be a Peruvian headache society, because I've seen people from Peru at International Headache Society or even at the American Headache Society. So but learning about migraine is a really good idea. The more you learn, the better you do. And sometimes you need to know more than like the primary care doctor so that you get the right treatments. But you can Google University of Utah Headache School. We also have a dizzy school. So University of Utah Dizzy School, University of Utah Headache School, and both of those have little handouts and things, not in Spanish yet, which would be a goal for us, but at least we've got English videos about questions about migraine, like what's a basic migraine?
We have another question. Another question in the audio is: in the case of the migraine aura status, what is your approach?
Migraine aura status.
Yeah.
Status. Well, there you really want to stop. First of all, you need to know what's causing it. Is it just that they've gotten a migraine? the definition of status migrainosus is not what you think. It's having several migraines with or without aura in a row, like several in a, like, you know, all of the time. Like have one and then you have a few hours off and then you have another one and then you have a few hours off. So some of these people, we've even had to admit them to the hospital and do intravenous dihydroergotamine. But you want to prevent migraine and then you treat the migraine when they get it. But it sometimes can be very difficult, and that's where you probably want to work with a neurologist to help you with that.
Yeah. What is your what do you do in case of the children cases? Is about what is the preventive treatment for the children?
So children, well, there are, you can prevent migraine in children, but there was a big study done in the United States in children where they randomized them to migraine or to treatment with amitriptyline, starting at 10 milligrams at night, or topiramate, or cognitive behavioral therapy. And they found out that those children who got cognitive behavioral therapy did just as well as the kids who got a drug. And so many times just cognitive behavioral therapy for children is all you need. Addressing depression or anxiety, if they have that as a comorbidity. But in children, the drugs that we often use are a low dose amitriptyline and sometimes topiramate. Some pediatricians use periactin or cyproheptadine, but that makes kids sleepy during the day. So amitriptyline at night or topiramate are kind of the top two go-tos, but don't forget cognitive behavioral therapy.
Yeah, good, good. Is there any another question? Is Alfonso or not?
Yes, there is a question. Where in the brain does the aura start?
Very good question. So we think that the aura is a cortical spreading depression in the occipital lobe. And if you remember your anatomy of the occipital lobe, if it starts in the center and then goes out, if you think of that calcarine cortex, it's going in, right? And from the pole in. And usually it is thought that it's occipital lobe, and they've seen auras in pet studies. They've watched, auras develop in pets, and we think it is a cortical spreading depression, and it comes out of the occipital lobe. And that means it's in both of your eyes, going off to the side. And that's such an important question to really quiz the patient, because they usually say, oh, this thing happens in my right eye. Well, let me tell you, they didn't take their paper and look at the paper and see if they can read just with their left eye, because then when they look with their left eye, they go, oh, it's covering my left field too, my vision in the left eye off to the right as well. So it's always in both eyes, off to one side or the other.
Do you think ophthalmic migraine as a part of migraine, or do you think it's another entities, ophthalmic migraine, retinal migraine?
Retinal migraine. Okay, remember I told you retinal migraine is very rare and it's very hard to diagnose. And most of the people that I've ever seen that have said to have retinal migraine actually just had vasospasm of their retinal artery. And you treat that with a calcium channel blocker, and usually that stops the retinal vasospasm. And of course, you have to make sure that this isn't a transient monocular blindness from a carotid artery disease giving you, little emboli to the eye. So that's a tricky one. Retinal migraine is not common. It's very uncommon.
Another question, Alfonso, or está todo?
Are your brains full?
Estás en mute, Alfonso. Está mutado tu audio.
Ok, sí, no hay más preguntas.
Well, parece por la hora. Well, congratulations again, Dr. Kathleen Digre.
Well,
Great presentation. Wonderful.
Gracias. And I enjoyed being with you and happy to talk about visual aspects of migraine anytime because it's such an interesting topic. And when you're in clinic tomorrow, see how many patients you see in your clinic that have had migraine. And I think you're going to find that it's really prevalent. It's very prevalent.
Okay, thank you so much.
Yeah.
Thank you so much.
Adios. Adios.
Adiós. Ya,
Adiós.
Alfonso, ¿de repente del clan algo mencionar al final? ¿Del clan? ¿O ya
No te
tenemos
escucho.
todavía? ¿Tenemos presencia si en del clan algo acerca del curso internacional del clan? ¿Se podría mencionar algunos que permanecen
Bueno,
todavía?
se tiene que mencionar, ¿no?
Sí.
Para
Puedes invitar.
los próximos 6 y 7 de septiembre vamos a tener el primer congreso del clan que se va a realizar aquí en Perú, va a ser en el local de la Sociedad Peruana de Oftalmología. Ya en los próximos días va a estar presentada el afiche y los precios van a estar bien accesibles tanto para residentes como para asistentes, ¿no? Separen y marquen en sus calendarios viernes 6 y sábado 7 de septiembre. Es a la semana siguiente del Congreso Regional.
Importante para que se puedan inscribir, los invitamos a todos que puedan participar en el Club Latinoamericano de Neurooftalmología, que va a haber muchos speakers de toda Latinoamérica, como alrededor de 25 a 30 speakers. Los esperamos a todos. Muchas gracias. Muchas gracias a todos.
Gracias.
Hasta luego.
Chao.
Gracias, hasta luego. Hasta luego, Alfonso. Hasta luego.
Chao.
Nos vemos, chao.
Hasta luego con todos. Bye.